Hello, everyone. It's my great honor to be here in this symposium today, introducing our newly developed cognitive framework titled Cue-induced Retrieval and Reconsolidation with Episodic Foresight, or CIREF. My name is Parnian Rafei, and I am a graduate research assistant affiliated with the Iranian National Center for Addiction Studies, or INCAS, at the Tehran University of Medical Sciences. So to begin with introducing the CIREF framework, I have to briefly mention the cognitive impairments that are associated with substance use disorders. So different studies have shown that those who are struggling with a substance use disorder or addiction experience different kind of cognitive impairments, particularly in their memory and executive functions, cognitive demands. Different types of memory, such as working memory, episodic memory, prospective memory, and different subtypes of executive function, such as inhibitory control, the decision making, and so forth, are shown to become impaired for those people that are undergoing that are suffering from substance use disorders, and the deficits in cognitive domains not only contribute to the vulnerability and formation of substance use disorders, but also they contribute to the chronicity and the risk of relapse in those who are suffering from substance use disorders. That's why we highlight the need of trying to enhance these cognitive domains when it comes to addiction recovery. Cognitive interventions, cognitive training, cognitive boosting, cognitive rehabilitation, and that has different names, is now introduced as an adjunct treatment for addiction in light of those cognitive deficits that I just mentioned. There are several key findings in the investigations that probed into the efficiency of the cognitive boosting and cognitive remediation interventions for addiction treatment. To briefly mention some of these key findings, studies have shown that cognitive trainings could be promising for enhancing the cognitive deficits that are related to addiction recovery. Some kind of cognitive interventions, such as attentional bias modification and inhibition control or inhibitory control training, was shown to be able to attenuate the response of the salient system of the brain. And working memory training and goal setting trainings were shown to be able to improve a future-based decision making, which is critical in the context of addiction and risky behaviors. And last but not least, those cognitive interventions that reduce drug-related salience work via prefrontal cortex or amygdala brain networks. So there are different types of cognitive interventions. Each of them showed some promising effects, but we came up with the idea of combining the different psychological and cognitive interventions in order to fill in the gaps and limitations of each of those interventions. We recently developed the Cue-induced Retrieval and Reconsolidation with Episodic Foresight, or CIREF framework, which I'm now going to briefly mention its active ingredients. The first active ingredient of the CIREF framework is cue exposure therapy as a psychological interventional framework in which the drug-related cues are repeatedly presented to the patient in the absence of reinforcements, aka drugs. The second active ingredient of the CIREF framework is memory consolidation. Memory consolidation is a process in which a reactivated memory, a memory that was formerly consolidated in the memory system, is reactivated and could be updated, modified, or disrupted within a limited time frame. And the third active ingredient of the CIREF framework and the core component of this interventional framework is episodic future thinking, which refers to the capacity to imagine, simulate, and project oneself forward in time and to pre-experience personal, novel future events. So now I'm going to briefly explain about each of these, let's say, modalities of the CIREF framework, their limitations, and lastly, why we're going to combine them and why we hypothesize that the combination of these three active ingredients could be helpful for addiction recovery. The first modalities, cue exposure therapy. Cue exposure therapy is a psychological intervention or psychological treatment. It is theoretically based on the Pavlovian classical conditioning theory, and it aims to extinguish the conditioned craving-provoking effects of drug cues using extinction procedures. As I also told you before, in the cue exposure therapy, during this kind of therapy, the patients are exposed to different kind of drug cues, like the pictures of the drug and etc., which provokes craving. And these drug-related cues are presented in absence of the drug itself, which is the reinforcing feature. It is hypothesized that the conditioned response, which is the drug-seeking or drug-taking behavior, it goes through some kind of extinction after this procedure. Seminal findings related to cue exposure therapy for addiction recovery showed promising results, but there are also numerous negative results related to these investigations, mostly related to the efficacy in terms of craving, relapse rate, and the number of abstinence days. The most important limitation of cue exposure therapy is regarding the translational issues. There is little to no evidence for a reduction of cue reactivity in real life settings, which leads to lessened problematic drug use. And that's why we thought that we could combine cue exposure therapy with other promising interventions to be able to boost its efficacy. So we thought of memory reconsolidation just because, maladaptive drug-related memories are the hallmark of addiction and could contribute to the risk of relapse and addiction chronicity. In memory consolidation, those drug-related memories are targeted since, given the fact that the old consolidated memories are liable to change and then become reactivated for 1 to 6 hours, a limited amount of time. So the aim of memory consolidation strategy is to renew the drug-related memories and their related motivational and emotional salience in order to reduce the risk of relapse. So the formerly consolidated and stored episodic memories go through some kind of changes and modifications upon being reactivated. The effectiveness of memory consolidation also shows mixed results. Let's say a recent systematic review by Dr. Sanjeev Kambud's lab shows that memory consolidation techniques could be promising and helpful for addiction treatment. However, they are highly dependent on the efficiency of reactivating maladaptive drug memories. And there is a highly important limitation regarding this kind of intervention, and it is that most of the investigation that probed into its efficacy were often supplemented by extinction-enhancing pharmacological treatments, such as D-cycloserine or beta-adrenergic antagonists, such as propranolol. So this is also another limitation that we tried to address with adding another modality which showed promising results named episodic foresight or episodic future thinking. The theoretical basis is that the episodic future thinking is the prospective facet of human episodic memory, which is also called mental time travel or prospection. These terms are coined by Professor Endel Tulving. There is one taxonomy for episodic foresight, which consists of simulation, prediction, intention, and planning. I'm going to further discuss how we converted this taxonomy into steps of the CIREF framework. The mechanism is that the patients try to evaluate their behavior's long-term outcomes by pre-experiencing future actions. And that's the episodic foresight mechanism of action. And the aim is broadening one's temporal window by simulating the value of the reward, which is also called reducing discounting rates or delay discounting rates. So when a patient tries to pre-experience those drug-related events and experiences that might happen in the future, they could be able to evaluate that behavior and try to increase their future sightedness. And the efficacy of episodic future thinking for addictive behaviors is limited because limited trials were done on substance use disorder populations. However, those limited results show promising results, and the limitations also need further research. So I'm just going to briefly explain how does the CIREF framework works. You can see in this figure that the process starts with the cue exposure. The patient is exposed with a drug-related cue and is asked to retrieve a drug-related memory that happened to them in the past. A formerly consolidated drug-related memory is now reactivated and could undergo different kind of modifications. You can see that the old memory goes into the episodic future thinking stage, which has 4 sub-steps, including simulation, prediction, intention, and planning. That was I explained before in the taxonomy. So you can see that the first step is simulation. The patients are asked to envision future drug-related events. The next step is prediction. The patients are advised to predict outcomes of that simulated event, whether they're going to approach the drug or avoid the drug, and so forth. And the third step is regarding intention, which is relevant and kind of let's say, similar to Gollwitzer's implementation intention framework, in which the patient is asked to form new intentions and set new goals in a guided setting. And the fourth phase is planning. The patient is now ready to plan and set different plans based on the reconsolidated memory, the intention and goals that he or she formed during the intention phase, which is also as a result of the prediction and simulation. And lastly, the new memory is formed, the new reconsolidated memory that underwent modification during all the CIREF steps, and it becomes locked and consolidated and stored again. So we hypothesize that CIREF as a multifaceted approach targets both past and future-oriented aspects of drug-related memory, and has added values when we want to compare it to, let's say, cue exposure therapy and memory consolidation per se. Because it uses implementation of goal-based strategies. So memory consolidation and cue exposure therapy are mainly based on the past-oriented aspects of drug-related behaviors and addiction-related behaviors, but implementing goal-based strategies for the future is something that is new in the episodic future thinking in the CIREF framework, which leads the patients to make healthier decisions by viewing future events as more connected to their present choices. Different studies also show that episodic future thinking and adding episodic future thinking to a cognitive intervention could improve the efficiency of other psychosocial interventions. And lastly, reshaping maladaptive drug-related memories toward more adaptive memories could support and aid addiction recovery. For more details about the CIREF framework, you can take a look at our opinion paper titled Imagining the Future to Reshape the Past. And our next steps are the ongoing pilot studies and feasibility trials that are happening right now. So there are 3 ongoing projects in the CIREF framework, 2 of which are, halfway through their work, and one of them, which is the last one, recently got the IRB approval. Just going through them briefly, you can see that the first study has 3 sessions of CIREF intervention and cognitive reappraisal in cannabis users, and we investigate its effects on craving, emotion regulation, and neural drug cue reactivity using fMRI. The second investigation consists of 3 sessions of CIREF intervention in abstinent opioid users in an MMT clinic, and we probed into its effects of CIREF on craving, neuropsychological measures, and delayed discounting. And the last project that recently got the IRB approval and is yet to be started very soon has 4 sessions of CIREF intervention in a group setting in abstinent heroin users in inpatient MMT clinic. And we are planning to delve into the CIREF effects on craving, addiction treatment outcomes, and neuropsychological measures. So thank you for listening to my talk. I am beyond thankful to all my supervisors for their help, support, and their helps in conceptual, let's say, in the conceptual framework of these cognitive intervention. The principal investigator of this project, Dr. Hamad Ekhtiari, and Dr. Tara Rezapour, and Professor Varun Bikal. So I am pretty much looking forward to your questions and comments. Since this is a new framework, we would be highly appreciative of your questions and comments regarding this new framework. Thank you for listening.